Good evening and welcome to EASL Studio, your weekly hepatology broadcast news. Tonight, we're going to discuss alcohol, cardiometabolic risk factors, and steatotic liver disease, from stigma to breakthrough therapies. My name is Aleksander Krag, and I'm privileged to have three international professors in the faculty today. That's Fredrik Åberg from Helsinki, Finland, Maja Thiele from Odense, Denmark, and Rinella from Chicago, United States. Welcome.
Thank you.
Thank you.
So, guys, I have a challenge for you. You will not be able to talk very much in the beginning. I have 8 questions for each of you, and you can only say yes or no to have a clear answer. Are you up to that challenge? Fredrik, you go
Absolutely.
first. Absolutely. And then afterwards, we can dig more into it. But I'm trying to understand your position on some, I think, which are important questions in this field. Instead of giving you 5 minutes to something we cannot really understand, then 1 second, and then yes or no. Okay, Fredrik, are you ready? We will go fast, and you should say yes or no. Okay, so first question. Has the new nomenclature of steatotic liver disease benefited research and development around alcohol-related liver disease?
Yes.
I'm looking forward to know why. Next thing, can we rely on self-reported alcohol consumption in trials on mid-ALD and ALD?
The question is still to me.
Yes, you get them all. Now you're sort of
I
in
get them all.
chair.
No. Yeah, my answer is no.
Okay. Can we rely on self-reported alcohol consumption in clinical practice when we manage patients with suspected steatotic liver disease?
No.
Okay, and next one here. Should we leave out histology and rely on non-invasive tests in clinical trials in mid-ALD and ALD?
Yes.
Okay, should PEth or CDT or some other markers be used in the MASH trials to rule out mid-ALD and ALD? That's not happening.
Yes.
Very good. Okay, so now I actually got 3 categories here just to discuss which is actually the most important area to cover in ALD. So in trials in mid-ALD and ALD, where do they see the biggest unmet need? Is that in the fibrosis stage, what would be equivalent to F2 or 3 fibrosis, compensated cirrhosis, or decompensated cirrhosis, if you could decide?
I would say compensated cirrhosis.
Okay. Should all people with alcohol consumption be screened for alcohol-related liver disease?
Yes.
Okay, final one here. Okay, does there exist an optimal treatment strategy approach to patients with mid-ALD and ALD that people actually should know about?
Sorry, can you repeat that question?
Does there exist an optimal treatment strategy approach, a clinical approach to these patients? Plug and play. How do we approach them? How do we manage them?
Yes.
Great. I look forward to that. Okay, next in the firing line, Maja. Maja, Finnish people are allowed to talk a little slow. That's fine. But we expect you fast, and Americans always talk fast. So, Maja, are you up for it? Now you know the questions. Okay.
Yes.
Has the new
Rapid fire.
nomenclature, has the new nomenclature benefited research and development around ALD?
Yes.
Can we rely on self-reported alcohol consumption in clinical trials in mid-ALD and ALD?
Yes.
Wow. Can we rely on self-reported alcohol consumption when we manage patients in the clinical practice with steatotic liver disease?
Some Scandinavian disagreement, yes.
Oh, I look forward. Okay, should we leave histology out when we move forward with clinical trials in mid-ALD and ALD and go for non-invasive tests?
Yes.
Should PEth or similar be used in MASH trials to rule out mid-ALD and ALD?
No.
Okay, Maja, which one is the biggest unmet need in this space? Fibrosis, compensated, decompensated cirrhosis?
I would say fibrosis.
Okay. Harmful alcohol in patients with harmful alcohol consumption, should they be screened for alcohol-related liver disease?
Yes.
Okay. Does there exist a plug-and-play optimal or best scenario treatment approach or clinical approach to patients with mid-ALD and ALD?
No, not plug and play. We can
Okay.
discuss standard of care.
Okay. Maru, now you've had a lot of time to think, so we'll be sharp and short here. Okay, the one I can almost predict your answer to the first question, but let's try. Has the new SLD nomenclature benefited research and development around alcohol-related liver disease?
What do you think? Yes, I think yes. Yeah.
Yes, I look forward to learn more about that, because that's again how the field is evolving when you change things. Can we rely on self-reported alcohol consumption in clinical
No.
trials? No.
No.
Okay. Can we rely on self-reported alcohol consumption in clinical practice?
No.
Should we, and you should know because you suffered all the invasive studies, should we leave out histology and rely on non-invasive tests in clinical trials in med-ALD and ALD?
Maybe.
Okay. Then another one here. Should we, or should PEth or similar be used in MASH trials to rule out med-ALD and ALD contamination?
Yes. Yes.
Okay, which one is the biggest unmet need in this space? Fibrosis?
Cirrhosis.
Cirrhosis. Okay.
Mhm.
Would you screen for liver disease in patients with harmful alcohol consumption?
Yes.
Okay. Do you know of optimal treatment or clinical approach for patients with med-ALD, ALD that people should know?
Theoretically, yes.
Okay, great. I look forward to it. Let's open it up. Now we definitely got some agreement, so, or a little bit of disagreement also. So first, maybe try to understand a little bit of why the changed words definition. How can that help a research field, Maja? You
Well,
also
I think these sorry, I think these categories have existed for long, but the nomenclature has been key in operationalizing some of the concepts of med-ALD and ALD beyond what is often mentioned with the destigmatization. I think importantly also maybe the nomenclature has opened the eyes of both academic and commercial players who were previously exclusively focused on what we used to call non-alcoholic fatty liver disease, and now seeing the broad spectrum.
So you think that actually this, by combining it in a spectrum, in a family, has changed also the commercial players' view on this? This is interesting. But over to you, Fredrik, from your perspective, how do you see that this, Maja said it's more or less existed before, but why, what has really changed here?
What has changed? Well, I think, with rising obesity epidemic, I think we have more and more patients that have a load of metabolic risk factors and also have alcohol use that is above the limits for SLD. So I think it's changing in the way that we have more of these patients that now would be maybe categorized as med-ALD.
But Fredrik, do you think it's easier again to communicate, to work across the field, actually publish across? Before it was very much siloed, alcohol versus non-alcohol, which is basically artificial. Do you think this has softened up and improved opportunities to do good research?
I think so. I think, with the med-ALD category, it defines a kind of a distinct group that is easier to recruit to a trial. And I guess, what will be needed is more or less to validate the trials that are done in SLD also in this med-ALD group.
Okay, Maru, you're kind of the mother to this. I guess you were a little nervous before it was launched. So did it play out better than expected in terms of actually integrating alcohol and non-alcohol and see this?
I think it's achieved its intention, which was, in my opinion, to raise awareness of the importance of the synergy between alcohol and cardiometabolic risk, because we know that alcohol certainly accelerates disease progression in the context of what we would have considered MASLD or within that spectrum. So I think it's really highlighted that. I think it's increased awareness and it's elevated the importance of screening for alcohol use in practice, in the practice settings of people that are not focused on alcohol exclusively. We're seeing much more use of alcohol biomarkers. And I think all those things clinically are very good because they serve the patient well. And then from a research perspective, I think it's also achieved its objective because it's opened not only the field to allowance of a more liberal alcohol intake within the context of MASH and MASLD, because I think that's just the reality, and we're missing a lot of important patients. But also what has also emerged is some really interesting approaches using therapeutics that can benefit both alcohol intake, desire, and in addition to
We can
MASH.
get back to that, but you think that this way of seeing it actually, and also I think the visuals, your green table there has opened people's eyes up and said, okay, this is part of the same family, and the drugs you're seeing moving into med-ALD and ALD are actually coming largely from the MASH field.
Yeah, I mean, I think that it has increased awareness. There's a lot of details. The devil's in the details, though, right? Is how do we really define those boundaries? It's really, really difficult to do that. So.
Okay, no, let's move on. Let's send about the whole issue, because the whole thing there, largely where you put it, depends on how much alcohol people consume. And that's why I think it's very important and interesting to discuss how do we actually capture that best. And I think, Maja, you said we can rely on self-reported alcohol consumption. Can you explain why?
Well, it's historical. I mean, in alcohol use disorder studies, people have asked since 1948 what were the level of drinking, and this has been used in other fields in alcohol use disorder studies. And
Do you think it's accurate, Maja? Is it accurate enough?
I think so, because importantly, it holds prognostic information. So when we look at population-based studies, when we look at other types of study, you can actually produce information about the risk of liver-related death, of liver-related events from self-reported alcohol use. So I think there are two aspects in how accurate it is. One, it's accurate enough for prognostication. Two, does it really matter if it is super, super accurate? I think not. And that I think is my point.
Okay.
I think establishing a certain use above a certain threshold, maybe into risk categories, is what we can expect. Also, just because of recall bias. I mean, who here are able to recall what they drank 3 weeks ago, right?
But still, you need some kind of precision to put them in the categories, and I guess for clinical trials, you will still feel comfortable going forward with a clinical trial where it's the self-reported, or would you rather do a marker, PEth or CTT or something?
I think the issue here is that there's also a technology aspect to it. The markers that we have so far are not precise estimates of the alcohol use. There are vast unknowns in the half-time of, say, PEth, which is what is often mentioned, so that you would see a rapid decline shortly after alcohol ingestion, and then kind of flatten out of the curve. So when we are saying, oh, PEth is an accurate measure of past 2 weeks alcohol use, we really have no clue, because it's not like smoking, where you usually smoke around the same amount of cigarettes per day. Alcohol use goes up and down, and there are weekly big deviations, and we just don't know these markers' accuracy for the calibration of the exact use. And again, this is also seen with PEth. I mean, we have a low threshold of 20 nanograms per milliliter and a high threshold of 200. And in between, in this huge gray zone area, we really don't know what it means.
So we still need to learn, I guess, a lot about PEth. Fredrik, can I ask you, so I acknowledge what Maja is saying, but I guess there are also several publications out there of massive underreporting, both in clinical trials, observational studies, even register-based studies, but there seems to be an information bias about alcohol. So you were actually arguing for that we could not rely on self-reported. What is your position on this, or why?
Well, I think we can't, as Maja said also about the recall bias, I don't think we can really rely on anyone's self-reports of alcohol use. And I think there are a lot of data showing that actually the more alcohol you use, the worse you become in quantifying the amounts of alcohol you're using correctly. So, I mean, there is intentional and unintentional underreporting in particular. So, I mean, this becomes quite of a mess. And I agree, there are issues with PET. Still, I think PET is the best that we have right now for clinical use. But the studies, they're done so that they're compared with the self-reports. So, I mean, we don't have a gold standard measure of alcohol use.
But for example, at UEG there were data presented from the resmetirom trial, and it was actually less than 10% of the trial participants who had a PEth above 20 nanograms per milliliter, and 20 nanograms per milliliter is just, you know, low drinking.
Yeah,
you could drink
normally.
But Maja, isn't that again
Right,
for...
it's not
Okay,
too
Maru,
much.
please. Yeah.
No, I mean, as far as that goes, though, they did not have PEth on everybody at all, actually. And so they had PEth more on people in the cirrhosis outcomes trial, but not in the large phase 2-3 trial. That's really, they didn't have those data. And if they do, they have it on a minority of patients. So I don't think we can draw conclusions about that. I think in a cirrhosis trial, if that's what this particular abstract was on, I don't know. Was it in cirrhosis? Probably in their outcomes trial?
Yeah.
I'm going to guess.
Maru, maybe
gonna
you
guess
can
it,
explain
so
a
yeah.
little bit how you use, how you suggest to use PEth, because I guess it among the one we have on the shelf, it seems to be, at least at the moment, the one that it seems most attractive. But how would you use PEth, maybe first in the clinical trial, but also clinically, because it's being more and more wide used?
Yeah. So so clinically, I use it in every new patient that I see with liver disease, period. If there's any positivity or history that picks up regular alcohol use, then I check it when I see them in follow-up, probably at least once per year. In a clinical trial is pretty commonly being used at entry for all phase 3 trials that I'm aware of at this point. And it is, I'd have to look at the frequency, but it's used at entry, and then I think it's used at least at one midway point. So I think it's been incorporated into clinical trials.
But that's also
one
a
of
new
them
thing. That's a new thing, isn't it? That was that also led by this whole new thinking, and actually some of these people like yourself that now I might offend you, that forgotten that alcohol was an important part of liver disease, suddenly knew that this was important.
Well, as you might suspect, I never forgot that. And I've actually been pushing for that for 5-6 years at least now. And so, you know, not to mention, I'm sure any of us who do research in the MASH side have seen patients, you know, showing up at the ER thinking they developed their new episode of decompensation with hepatic encephalopathy, only to find their blood alcohol level 400, right, in the ER. So people definitely underreport alcohol use. And so I think we'll see more clarity in the future with respect to the impact. And one thing that Maja mentioned, which is absolutely true, and you know, maybe Fredrik mentioned as well, is that there's a lot we don't know about PEth yet, and there's also a lot of factors that influence its metabolism. So in cirrhosis, actually, the clearance is very different, right? So you have to, you know, take all those things into account. And I'm concerned a little bit about you know, anything over 20, you know, 20 to anything over 200, between 20 and 200 still being considered a lot of alcohol ingestion. I think it really depends.
Let me stop you there, Maru, and maybe say, okay, you use it a lot. How do you then take consequences of this? Let's say you have a patient, it's whatever, 180. What do you do?
So I talked to him about the harmful impact of alcohol. I assess whether they would be best served by counseling for alcohol use disorder. I do spend quite a bit of time on that. I talk about the synergistic effect of, you know, weight and alcohol use in a figure that was beautifully. I've actually shown people your figure, Fredrik, in the paper showing waist circumference and and alcohol intake. So it's an important point of discussion for me if I pick that up.
Okay, Fredrik, you're not allowed to show a slide, but that figure that can even help Maru, we need to know, can you explain what is that figure? And what is the important thing with the abdominal perimeter, etc.?
Which figure were you referring to?
So one that you did, I think, and it was in a review, and it basically looked at quantity of units of alcohol ingested by, sort of waist circumference, and the concept being that even low levels of alcohol intake, if you have elevated waist circumference, the impact was about fourfold, something like that, roughly.
Yeah. So I think, there's the synergistic affections suggested by many, mostly epidemiologic studies, but also there are more and more mechanistic studies that support this idea that there are some synergistic, maybe supra-additive interactions. And I also think, as Maru said, the other way around. So if you can treat both of these, you will have like synergistic benefits for the patients, for the risk of outcomes. So I completely agree.
I think was also part of the idea here, that how should we see these diseases? So we tend very much, Fredrik, maybe a bit more from you also, focusing, we've been for a long time very liver-centric, because that we understand it, but you're already there reaching way beyond. But before we go to talk to how we actually do the best treatment, I would like to discuss the screening, the case finding. It's well known that patients where alcohol is the lead driver of disease are often diagnosed late and the prognosis is poor. You all said yes to screening. Maja, you're an expert and work with all kinds of tests. So if you could decide, what would be an optimal way of early detection and case finding with patients with alcohol consumption?
I think first and foremost, we need to pool all at risk for SLD together. This is what this is all about, right? So we have been so used to seeing flowcharts for early detection of MASLD, where you are detecting diabetes and abdominal obesity, etc. And then flowcharts for alcohol use disorder and screening with audit score, and then a non-invasive testing. But if we actually combine and look at the steatotic liver disease umbrella, then we can easily say we screen for all the known risk factors for steatotic liver disease, including alcohol, and this can be with like the audit C. It's very easily delivered to the patient, a short form of the audit questionnaire. And then you also screen for the metabolic dysfunction components. And then after that, the liver risk screening. And
what would you do? So I completely get it. That's also follow the logic of the nomenclature definition.
Exactly.
So what would you then apply if you should be a more wide use screening tool that can be used in primary care? I guess that's where the patients are, most of them, isn't it?
Oh yeah. I mean, this is all primary care. No hepatologists involved, preferably. Yeah, I would. Many people are mentioning FIB4. I'm not a huge fan of FIB4, especially because we see that it has not a perfect sensitivity, so we are actually missing quite a lot of cases with FIB4 below 1.3. And also it leads to a huge amount of people being referred. In population-based studies, it's almost half.
What would you use then, Maja? I think many here will agree. What should we do? We need to give the primary care physicians some help. We say we want to find them, we blame them for too late diagnosis, and yet they have no clue what to do because we don't give.
I think for now it can be FIB4. It can be some of the other multivariable algorithms which can be incorporated into lab systems. I think that's the key.
The more automated approaches.
Super easy.
What about reflexes? Now, a little bias is a study. We did a study with reflex testing for alpha, another test where, and can you just explain a little bit what dynamics that actually introduced, because that could forecast the future where you can have something a bit more automated.
Yeah, so we did a screening study in a Danish population, and we saw that I think it was in an at-risk population, and 30% had an elevated FIB4. But then we tested with the ELF test, which is a commercial biomarker consisting of 3 components of kind of the extracellular matrix in those with intermediate FIB4. And this led to a vast reduction in referrals, so that eventually I think it was around less than 20% needed referral for subsequent liver stiffness measurement.
More
so I
than
think
half
these
that,
types
yeah.
of, just to, referring a patient to secondary care is always very expensive. So we may use some money on the more expensive testing if this allows us to keep patients in primary care.
Okay, so let's try to focus on how we manage these patients today. I guess we all agree it's more holistic approach. So back to you, Fredrik. You already opened it a little bit, but let's say you got a patient, one of Maja's patients coming in there, positive. There's an ELF test or one of your tests that is actually positive or equivalent, and you find a TE of 11. What do you do?
Okay, so is this a SLD patients or meta-ALD or ALD?
No, this should be, let's just call it ALD. This is the patients that on average consume 40 grams of alcohol a day.
Okay, so my primary discussion would be about alcohol and telling the harms of alcohol and putting the goal to stop alcohol use. That would be my priority, but also I would discuss and check for the cardiometabolic factors. And of course,
Can you mention these just quickly? What cardiometabolic is it actually? We can very easily test for. There are tons of treatments for. That is no excuse we don't apply.
Well, my focus would be on overweight, obesity, abdominal obesity, and diabetes, and maybe insulin resistance if we can measure that somehow. Those would be my priorities.
Maru,
Later,
please continue, Fredrik.
Yeah, later, also, I mean, discuss smoking, nutrition, physical activity, stuff like that.
I think it's important, and I think there are now several studies showing that this specific information about liver harm actually seems to be enforcing changes in behavior with less drinking, better exercise, and weight loss. So, Maru, from your perspective, what of these patients should be seen by guys like us, and which ones could go to primary care? Where to make the cut? Because there's a lot of people out there with risk of liver disease.
Yeah, it's a good question. I think it depends on the health system that you're talking about. I mean, for example, in the UK, where they really want a minority of patients referred to specialty care, then you'd use higher cutoffs so that you may be more specific, but you're going to lose some patients with advanced fibrosis. So that, again, like I said, I think that depends on the health system. I think for the US, I think using the 1.3 cutoff is okay, but I would prefer, of course, that we use secondary testing as well, because to Maja's point, once you develop more advanced fibrosis, which you're going to see in an alcohol, in a met-ALD or more ALD population, you're, the negative predictive value of the FIB4 less than 1.3 is going to really, really go down. So you're going to lose a lot of people, about 30% actually of people with advanced fibrosis. So, ideally you should have secondary testing. I think ELF is a very reasonable second step because it's a blood-based test, but liver stiffness I think is probably better than ELF.
So who will you, again, back to the question, I get it there, but from who would you in your clinic, forget all the others, but who would you keep there? Who do you say they are probably better served with me? And who would you feel comfortable sending back to primary care after you have this different consultation, check their other cardiometabolic risk factors? Where should the split ideally be in a system like yours?
Well, I would say since we have therapies that are going to benefit people with F2 fibrosis and beyond, I would say anybody with clinically significant fibrosis, I would be interested in keeping in my practice because I can treat with certainly with resmetirom, but also with GLP-1s that we think are also going to be effective in those patients. And then cirrhosis, those patients should be followed in hepatology, I think, without question. Yeah.
Okay, Maru, you're not off the hook yet. So clinically significant fibrosis. Okay, how do you define that on a non-invasive test? What is your cutoff?
Yeah, so you can use a fast score, for example, greater than
I guess most people
0.67.
will use T. What would be a T cutoff of a patient you would be comfortable or feel that this is actually a good rule in
Yeah.
for advanced fibrosis?
So I would say, advanced fibrosis is a bit different, but I would say clinically significant fibrosis, higher than 8.5 would start to get you a little bit concerned. Certainly greater than 10 would get you concerned, especially if it's aligned with another non-invasive test that's also sort of in that ballpark. I would keep those patients and either treat them with therapies that we know are probably beneficial, or do a liver biopsy.
Okay, wonderful. So we're running a little bit out of time here, but now I think I want to ask you here for the last thing, because this field is moving, it's changing. There's a lot of research coming out. There's a lot of new drugs being tested that could potentially also help people where alcohol is the lead driver of disease. So Maja, for you, if you look 5 years down the road, you know a lot, but in the crystal ball, so maybe a little bit, what do you see, and also a little mix of what you see and what you hope for? What is actually in the horizon that could potentially change the life of all these people out there that so far have not really had any specific therapy on the shelf?
I think for Med-ALD and ALD, my hope is that we vastly improve case finding, because this will shed light on a big group that are currently going underdiagnosed. This is why we get so used to seeing patients with ALD and Med-ALD when they decompensate. But when we improve case finding, we thereby open a window of opportunity. And I think this will be the key for actually changing a large proportion of patients' lives. When we have 5 years before decompensation and symptomatic liver disease, then we can actually do something with the pharmaceutical options. And I hope this will happen before 5 years.
Wonderful. So that's basically the game changer. Again, also probably the reason why you picked that actually would be important to treat fibrosis
Exactly.
and not cirrhosis, because then you can actually prevent cirrhosis. So that's a good point from you, Fredrik. Again, looking in a mix of what you see on the horizon, also what you hope for that can be transformative. And Maja already took early detection, so you cannot say that.
Well, I'm quite excited about the GLP analogs and the upcoming dual and triple agonist that, as said, not only treats the metabolic problem, but also reduces drinking in many patients. So I'm really excited about this. But also the point that Maja took, and I would take that maybe further, because, okay, finding the patients, that will be really important, but also linking these ALD, Met-ALD patients to kind of effective and sustainable models of care that I think we have for the MASLD patients. We have models of care for diabetes and obesity, and we can link that basically to those. But for the patients with maybe AUD, we, at least in Finland, we don't have any good models of care. So their healthcare contacts come from visits to the emergency department. So we have to develop these care models. I think that will be really important.
That's a good. So second one, care models. And I think both of the point you say there's links very much with the consensus of the patient's trajectory we will have in the EASL SLD summit in Estoril in Portugal. So do go there. So for you, Maru, now we've heard two other good things. If you should add something else that could be important that will hopefully happen in 5 years, that would be transformative. What would that be?
So I do want to end. Both of you have made amazing points, and I will emphasize that what we're actually saying is, really moving into a patient-centered care model where we have a truly multidisciplinary approach and holistic approach to the patient. So that's where we need to be 100%. And I think this is going to help us get there closer. But what I think is critical is biomarker development in this space. So I would love to see more accurate biomarkers for alcohol intake, not so much so that we know what the truth is per se, just to be able to categorize people, but so that we can better understand, how alcohol impacts individuals differently. Because as we know, you can have 100 people drinking excessively and only like 25% get cirrhosis. So better understanding, what makes one person develop progressive fibrosis and the other not, beyond the risk factors that we know in a more quantifiable level. I think that'd be useful.
These are some wonderful wishes for Christmas in 5 years. I think I will end it here, and I definitely see a very interesting journey, and I also see a future where we will have something that can change the lives of basically millions of people. So I want to thank you very much for joining here. It has been a great discussion, and I would love some time to invite you back and follow up on this. Otherwise,
Thank you for the invite.
Thank you.
end the EASL studio here, and as always, remember to join EASL, become a member, and remember there's an exciting episode about sarcopenia coming up next Wednesday.